Good afternoon. My name is Dr. Eric Chang, and I am the head of the Department of Radiation Oncology at the Keck School of Medicine. The title of my talk today is Indications for Whole Brain Radiation Therapy versus Radiosurgery in the Management of Multiple Brain Metastases. The learning objectives for today are to review the role of SRS vis-a-vis whole brain radiotherapy in the management of brain metastases, and to review some current trends related to brain metastasis management. I'd like to outline my talk, where we'll begin with a background with some demographic trends of brain metastases. We'll go through some key randomized trials and also review toxicities of modalities. And then finally, we'll close with future directions. So this is a recent illustration showing the relative incidence of various brain metastases from different primaries, such as lung cancer, breast cancer, renal cell carcinoma, melanoma, and colorectal or GI cancer, where lung cancer is the most common cancer in terms of the relative incidence of brain metastases. I'd like to forecast the evolving relative roles of whole brain radiation therapy and radiosurgery, where we are seeing a continual and persistent decline in the utilization of whole brain radiation therapy, while we're seeing an increase in the utilization of radiosurgery due to more sophisticated technology, more targeted therapies, and the advent of additional randomized trials showing support for radiosurgery. Of course, there are patients with low performance status, leptomeningeal disease, and uncontrolled disease who will still be candidates for whole brain radiation therapy. This slide shows you the demographics of the aging baby boomer population, where the proportion of people who are seniors is rising according to each decade. And what this aging demographic indicates to us is that there will be an increased incidence of new cancer cases, and therefore an increasing incidence of metastatic brain disease development. This is a slide showing you the number of metastatic patients treated worldwide from 1968 to 2010. It's showing you the cumulative incidence of patients treated with Lexel Gamma Knife treatment, which is a surrogate for all patients being treated with radiosurgery. These are guidelines released by the ISRS organization for patients with 1 to 4 brain metastases, showing various key clinical trials addressing the question of management of 1 to 4 brain metastasis with radiosurgery alone or radiosurgery plus whole brain irradiation. A trend to be aware of is that more effective systemic therapies may be translating into increased CNS metastases. In particular, women with HER2-positive breast cancer, the widespread use of HER2-directed therapy with trastuzumab has unmasked a population in whom CNS progression is a significant source of morbidity and mortality, since trastuzumab does not penetrate the CNS but is effective outside the CNS. While whole brain radiation therapy comprehensively treats the brain, it doesn't eliminate all brain metastases. This is shown diagrammatically, where all brain metastases are treated with whole brain radiation therapy, and you can see a subset of the lesions are able to break through the whole brain radiation therapy treatment, requiring post-whole brain treatment in the terms of salvage treatment or some type of palliative therapy. Sophisticated platforms do increase access and efficiency of radiosurgery treatments, and this is an example of the wide variety of platforms that are available to treat metastatic brain disease today. The issue is that technological feasibility versus evidence-based practice leads us to questions about how best to utilize this technology. Current sophisticated radiosurgery units allow treatment of a large number of brain metastases in a single session with greater efficiency than was previously possible. This newfound capability begs the question, just because the technology allows us to treat greater than 4 lesions, does it mean that we should? So the challenge is performing and completing next generation randomized trials for 4 to 15 brain metastases. Such a trial is currently ongoing and stratifies patients according to intracranial volume, number of lesions, and histology. Patients are randomized to whole brain radiation therapy or radiosurgery alone. This is the Canadian Cancer Trials Group trial, which opened in 2018, which stratified patients according to number, ECOG status, size, and volume. Patients were stratified according to DSGPA, use of targeted or immunotherapy, radiosurgical system, or histology, and randomized to radiosurgery or whole brain radiation therapy plus memantine. So does volume of metastases matter? Is it better to have 5 small brain metastases or 1 very large brain metastasis? Volume probably does matter and may even be more important than the number of lesions. This is a paper from the University of Pittsburgh which looked at 4 or more intracranial metastases and found that for patients fitting into this scenario, total treatment volume was the most significant predictor of survival. So let's do a treatment toxicity comparison. Potential radiosurgery toxicities include rare acute toxicities such as headaches, nausea, vomiting, aphasia, motor neuropathy, seizures, swelling, and hemorrhagic stroke, as well as rare late toxicities such as radiation necrosis, radiation-associated secondary malignancies, and death, although this is extremely rare. Potential whole brain radiation therapy toxicities include neurocognitive deficits, permanent alopecia, skin erythema, hyperpigmentation, taste alteration, fatigue, otitis media, xerostomia, psychomotor slowing, leukoencephalopathy, radiation recall with chemotherapy, and concurrent chemo whole brain radiation therapy, which is ill-advised. The MD Anderson randomized clinical trial schema, which I led when I was there and was presented at the ASTRO plenary session in 2008, stratified patients according to RPA class, number of lesions, and histology. Patients were randomized to receive either radiosurgery plus whole brain radiation therapy or radiosurgery alone. The primary endpoint of this trial was cognitive decline in learning and memory. The Hopkins Verbal Learning Test, which was the primary endpoint, was used to measure decline in learning and memory by detecting a 5-point or greater drop 4 months from baseline. The results showed of this study that patients who were randomly assigned to receive SRS plus whole brain radiation therapy had approximately twice the probability of developing neurocognitive deficits as measured by the HBLT test, about 50% in the whole brain radiation therapy arm and 25% for patients who were randomly assigned to the SRS only arm. Study conclusions were that SRS plus whole brain patients were at greater risk of significant decline in learning and memory function by 4 months compared to the group that received radiosurgery alone. Initial treatment with combination SRS and close clinical monitoring is recommended as the preferred treatment strategy to better preserve learning and memory in patients with newly diagnosed brain metastases. So what does close clinical monitoring mean? Well, according to the NCCN, this means brain MRIs every 2 to 3 months for the first year and then every 4 to 6 months indefinitely. ASTRO has released a Choosing Wisely position statement in 2014 indicating that the addition of whole brain to radiosurgery is associated with diminished cognitive function and worse patient-reported fatigue and quality of life. These results are consistent with the worsened self-reported cognitive function and diminished verbal skills observed in randomized studies of prophylactic cranial radiation for small cell or non-small cell lung cancer. Now let's look at radiosurgery for single brain metastasis and the probability of achieving tumor control. This is a study that was done at the Cleveland Clinic involving 202 patients with 375 lesions treated between 1997 and 2003. The 1-year local control rates by margin dose were for 24 gray 85%, 18 gray 49%, and 15 gray 45%. The hazard ratio for local failure was 0.277. This shows you graphically the time to local failure stratified by dosage. So the take-home message from this is that with the higher doses and therefore very small lesions, one can expect fairly good control rates of lesions treated with radiosurgery. However, for patients who are treated with 15 to 18 gray for intermediate or larger lesions, the outcomes are somewhat unsatisfactory. An outcome evaluation of patients treated with fractionated gamma knife radiosurgery for large brain metastasis was performed in a dose escalation study by Kim et al. This is showing you the waterfall plots where the reddish bars indicate progression and the green bars indicate response or stable lesions. And these are divided into groups such as 8 gray per fraction, 9 gray per fraction, and 10 gray per fraction. You can see fairly robust responses and changes in tumor volume for these 3 dose levels. The next trial I'd like to discuss is the NCCTG N0574 Alliance Study, Phase 3 randomized trial of whole brain radiotherapy in addition to radiosurgery in patients with 1 to 3 brain metastases, published in JAMA 2016. The background is that cognitive failure is which has a worse cognitive impact, tumor recurrence or whole brain radiation therapy. The design of this trial was such that patients with brain metastases were stratified according to age, extracranial disease, number of brain metastases, and institution, and randomized to radiosurgery or radiosurgery plus whole brain. The primary objective was to determine if cognitive progression at 3 months post-radiosurgery is less with radiosurgery alone than SRS combined with whole brain radiation therapy. The primary endpoint is cognitive progression at 3 months. These are the results. Cognitive progression at 3 months, measured by a variety of cognitive tests, showed that patients randomly assigned to radiosurgery had a 63.5% rate of cognitive progression. Patients randomly assigned to SRS plus whole brain had a 91.7% rate of cognitive progression at 3 months, and this was highly statistically significant with a p-value of 0.0007. So decline in cognitive function was more frequent with the addition of whole brain to SRS, as seen by the MD Anderson trial, which was discussed earlier, thus confirming the results from that earlier trial. This persisted at 6 months and was statistically significant. Long-term survivors, although not statistically significant, you can see that there is a trend with the SRS bars in blue and the SRS plus whole brain radiotherapy patients in orange, and you can see that the orange are trending lower than the blue bars. So in conclusion, this study found that a decline in cognitive function was more frequent with the addition of whole brain radiotherapy to radiosurgery, specifically in immediate recall, memory, and verbal fluency. Now these are companion randomized postoperative trials. This is the N107C trial, which was run by the NCCTG, and what this trial found was that for patients randomized to receive postoperative whole brain radiation therapy, there was a greater rate of cognitive decline than in patients who had radiosurgery postoperatively, and the cognitive deterioration-free survival was superior in patients who were randomly assigned to receive radiosurgery. However, the surgical bed control was seen to be 60% at 12 months in the radiosurgery patients and 80.6% in the whole brain radiation therapy patients. This is a surprising result because one would expect that radiosurgery would be superior to whole brain radiation therapy. There are a number of reasons that can be postulated for this, which I will not go into in this talk. There's a companion post-operative randomized trial done at MD Anderson by Mahajan et al. And colleagues. What this trial showed that the freedom from local recurrence was superior for patients who got post-operative radiosurgery compared to observation. And what the graph on the right shows is that for patients who had smaller tumors, less than 2.5 cm, these had the highest control rates, whereas for larger tumors, intermediate and larger tumors, the rates were not as good. I'd like to shift gears to part 2 of my talk, looking at whole brain radiotherapy for brain metastases. The indication is dependent on the spectrum of brain metastasis volume. Case 1 we can consider has no visible brain metastasis. This would be administering prophylactic cranial radiation. Case 2 would be small volume disease, 1 to 10 brain metastases, and case 3 would be greater than 10 plus brain metastases. For case 1, would we give prophylactic cranial radiation to most brain metastases primaries, excluding small cell lung cancer? The answer is no, we would not do this. For case 2, would we do radiosurgery for 1 to 10 brain metastases? The answer is yes. And for case 3, for greater than 10 brain metastases, we would individualize. This is the PCI trial run by the RTOG 0214 for non-small cell lung cancer. And what they showed was that observation, or PCI, showed no difference in overall survival and disease-free survival. However, there was an increased rate of CNS metastasis failure in the patients randomly assigned to the observation arm. Deterioration of Hopkins Verbal Learning Test with PCI for non-small cell lung cancer can be seen. You can see at 3 months, you can see the rate is 46% versus 13% in recall. And then this persists at 12 months for 26% in the PCI arm versus 7% in the observation arm. Both differences are statistically significant. This is showing you graphically how you can see the effects of the PCI at 3 months, and then there's a rebound, and then there's the effect again at 12 months. The next trial is the European trial, looking at radiosurgery or surgery plus or minus whole brain for 1 to 3 brain metastases. Small volume disease, should we give SRS plus whole brain radiotherapy? Maybe. What this trial found was that time to intracranial progression at new sites was improved with whole brain radiotherapy, and it showed that for patients who had surgery performed and had observation, there was a approximately 50% rate of local recurrence that you can see in panel B in the yellow curve, and that this rate was decreased significantly with the addition of whole brain radiotherapy. I think the take-home point from this data is that you cannot just do surgery alone, and that it needs to be followed up with some adjuvant therapy such as whole brain radiation therapy in this example. Survival with WHO performance score less than or equal to 2 was the same in both arms. They tracked the same, and overall survival was also the same between observation or adjuvant whole brain radiotherapy. What is the maximum number of newly diagnosed brain metastases that should be treated with radiosurgery? This is a moving target. It's unknown. This is a paper by the Japanese group led by Yamamoto and colleagues, published in Lancet Oncology, showing that for patients treated at multiple gamma knife centers in Japan, patients with 1 tumor had the best outcome. Patients were then categorized according to 2 to 4 and 5 to 10 tumors prospectively. This is non-randomized data, and showed that the outcome was about the same between 2 to 4 and 5 to 10 tumors, thus arguing for doing radiosurgery for greater than 4 brain metastases up to 10 metastases. This is a paper by Hughes published in the Red Journal in 2019, looking at 1 versus 2 to 4 and 5 to 15, and looking at the survival probability. And like the Yamamoto paper, you can see that patients did best in the single brain metastasis group. However, for patients with 2 to 4 or 5 to 15 lesions, these patients had very similar survival rates. This is just a case illustration looking at a 35-year-old patient with EGFR positive lung cancer with 34 metastases with a median volume of 0.026 cc's and a total GT volume of 4 cc's. All targets were able to be treated in 6 sessions over 8 days. Approximately 3 to 7 targets were treated each day using a prescription dose of 18 gray to 32 targets and 16 gray to 2 targets. A total of 45 shots were used. Most of the targets were treated with a single shot. So this is showing you just the technical capability of being able to treat a number of high lesions. Now this is the same group by Yamamoto looking at a multi-institutional prospective observational study of stereotactic radiosurgery for patients with multiple brain metastases. And this is looking at the mini mental state examination scores, which shows that most of the patients, 1 versus 2 to 4 versus 5 to 10, were about 86 to 88% preserved out to a number of months, 48 months. Radiation-related complications were about 15% or less, and then the rate of leukoencephalopathy was low at less than 1%. This last trial I'd like to present to you is a trial from Australia and multiple other centers led by Dr. Hong, looking at adjuvant whole brain radiotherapy versus observation after local treatment of 1 to 3 melanoma brain metastases. It's a multi-center randomized phase 3 trial. This trial is unique in that it focuses exclusively on melanoma patients, whereas most trials include patients coming from non-small cell lung cancer. This is a histology-specific based randomized trial. In this trial, 1 to 3 brain metastases seen on MRI were treated with either surgery and or radiosurgery. They were stratified according to age, sex, number of lesions, presence or absence of extracranial disease, and planned RT dose. Patients were randomized to receive whole brain radiotherapy or observation, and follow-up and outcome assessments were performed until withdrawal or death, and 3-month MRIs were also performed. Any systemic therapy was permitted. There was central radiologic review, and there was quality assurance performed on the whole brain radiation therapy. The primary endpoint of this study was distant intracranial control at 12 months. Secondary endpoints included local intracranial failure, overall survival, time to deterioration, quality of life, neurocognitive function, and health economics. Patients were accrued from 24 sites, including Australia, Norway, and the UK from April of 2009 to September 2017. 935 patients were assessed for eligibility. Ultimately, 215 patients were randomized, 107 to the whole brain radiotherapy group and 108 to the observation group. Primary endpoint analysis was performed in 100 and 107 patients respectively. These are the patient characteristics. About 100 patients had 1 lesion, 40 patients had 2 lesions, and 14 patients had 3 lesions in the whole brain arm, whereas in the observation arm, 107 had 1 lesion, 41 had 2 lesions, and 15 had 3 lesions. Distant intracranial failure was shown as distant intracranial failure incidence in this figure, showing there was 42% rate of intracranial failure distantly in the whole brain radiotherapy arm and 50.5% in the observation arm. This numerical difference did not reach statistical significance with a p-value of 0.16. The HR, or hazard ratio, is 1.28, crossing unity between 0.89 and 1.84. Distant intracranial failure was also looked at according to systemic therapy primary to endpoint. The whole brain radiotherapy arm receiving effective systemic therapy is in solid blue, and then the observation arm receiving effective systemic therapy is in solid orange. And you can see the results here. These are not statistically significant. Local intracranial failure, initial site of brain metastasis is shown, and there is a rate of 20% in the whole brain radiotherapy arm at 12 months and 33.6% in the observation arm, reaching borderline significance at a p-value of 0.05. Time to deterioration in ECOG performance status is very similar, and you can see that the two curves track with each other with a p-value of 0.32. Overall survival was very similar, 58% versus 54%, not statistically significant. Log rank p-value 0.89 with 45% neurological deaths. The study concluded that adjuvant whole brain radiotherapy does not improve intracranial control, survival, or performance status after local treatment of 1 to 3 melanoma brain metastases. For single brain metastases, better local control was seen with whole brain radiation therapy. The same could be achieved with cavity radiosurgery. Close observation while undergoing systemic therapy seems to be the preferred approach. And this is the first completed single histology adjuvant whole brain radiotherapy trial. The argument for using whole brain radiotherapy to treat occult microscopic disease is diminished by the use of immunotherapy and immune checkpoint inhibitors for brain metastases. I present to you this trial looking at combined nivolumab and ipilimumab in melanoma metastatic to the brain, presented by Taubey in the New England Journal of Medicine. And what you can see is that in the swimmer's plot is that there are a number of patients who did quite well, and there was only progression in 3 cases. You can also see the Kaplan-Meier estimates of survival here at 12 months, which is quite favorable. Lastly, I'd like to leave you with future therapies. This is an illustration showing the various potential targets that could be targeted in treating various patients with differing histologies. There are target opportunities for targeted therapy in the future that hopefully can be combined with the current conventional treatments. The last trial I'd like to leave you with is a unique biomarker-driven trial in brain metastasis, which looks at progressive brain metastasis and histologically confirmed solid malignancy, measurable CNS disease, and there are actionable alterations in CDK pathway, PI3 kinase, AKT or mTOR pathway, and ALK, NTRK or ROS1 translocation. This trial is looking at lung, breast, and other patients and is applying treatments such as CDK inhibitor, PI3 kinase inhibitor, or ALK, NTRK, ROS inhibitor. Brain MRIs and systemic staging are performed every 8 weeks until CNS or systemic progression. Thank you for your attention today.